I'd like to thank the other course directors for their kind invitation to this initial session devoted to the macroscopic anatomy of the vertebral canal and its content applied to the intrathecal drug delivery for the treatment of chronic pain. With this objective, an anatomical three-dimensional simulator system based on reconstructions of magnetic resonance images will be used. The vertebral canal is a long canal extending from the foramen magnum at the base of the skull to the sacral hiatus. It results from the superposition of adjacent vertebral foramina and encloses the spinal cord. The vertebral canal doesn't show straight path. On the contrary, it has the same curvatures as the spine. As we can see in this model, generated from a magnetic resonance, a typical lumbar vertebra consists of an anterior body and posterior elements forming the vertebral arc, including the vertebral lamina that give rise to the transverse and to the spinous processes. The stud pedicles arise on the posterior lateral aspect of the body and fuse with the lamina to encircle the vertebral foramen. Behind the pedicles, two additional processes appears: the superior and the inferior zygoapophysis. The spinal cord is the most important element within the vertebral canal. It has a non-regular cylindrical shape of about 1 centimeter in diameter. Its narrow distal end is called the conus medullaris. The conus usually lies at about the limit of L1. An important radiologic study with almost 700 patients has shown that the conus medullaris is actually located at L1 level in a high percentage of the general population. However, the caudal extension of the spinal cord follows a normal distribution and can reach the upper limit of L3. A classical approach in anesthesia at the lumbar spine corresponds to the medial approach. This method involves the introduction of the needle through the interspinous space to reach the vertebral canal. As its name suggests, this space is delimited by two adjacent spinous processes. The medial approach requires crossing successively the supraspinous ligament, this slender structure that jumps between the tips of the spinous processes, then pass through the interspinous ligament, this narrow sheet of collagen that fills the interspinous space. Sometimes the presence of midline cavities have been described. These cavities filled with a fluid could give a false impression of having reached the vertebral canal. And finally, the flavum ligament, composed mainly of elastin. It is one of the elements that forms the posterior limit or the posterior boundary of the vertebral canal. The loss of resistance sign is a common technique to identify the epidural space and is thought to rely on the penetration of this ligament. As we can observe in this anatomic preparation, the flavum ligament is a rectangular sheet attached to both edges of the lamina from contiguous vertebra. In fact, there is a single flavum ligament on each side, joining in the midline during the embryonic development. However, this fusion is not always complete and gaps can persist for the passage of a vascular pedicle. These gaps were observed in 20% of specimens at L1, L2 level, and in 10% at lower levels. This fact could explain that the sign of loss of resistance is not present in some patients. This is the three-dimensional configuration of the flavum ligament in which we have preserved this midline gap. The anterior portion of the ligament covers anteriorly the zygoapophysis joint, as we can observe here. The characteristic spatial orientation of this ligament explains its attachment in the inner surface of the superior lamina and in the outer surface of the inferior lamina. Crossing the flavum ligament, the posterior epidural fat is reached, which is located behind the dural sac. These fat pads can be easily recognized as hyperintense regions on T1 weighted images. This same disposition posterior to the dural sac is seen in the sagittal anatomical section. The fat compartment seems to play an important role in the local spread of lipophilic drugs, resulting in a high local drug concentration in the area infused. From the posterior epidural fat, drugs can spread into the lateral and then into the anterior fat compartment. This spreading has been demonstrated in cadavers by injecting stained solutions that seems to use small channels to be distributed through the epidural space and finally to the subarachnoid space. As we can see in this MRI T1 sequence, the posterior epidural fat looks like these triangular fat pads posterior to the dural sac. They have a small size in the upper regions of the spine and reach the largest size at mid-lumbar levels. This is the three-dimensional configuration of epidural fat deposits: posterior, lateral, and the smaller anterior fat compartment. The model shows a discontinuity between the different compartments, except at the caudal levels of the spine, where they usually converge. These discontinuities are caused by the proximity of the dural sac to the wall of the vertebral canal without fibrous adhesions. On the other hand, the lateral fat compartment fills the intervertebral foramen, surrounds the exit of the spinal roots, and is continuous with the paravertebral fat. The most important structures lying within the vertebral canal are the spinal cord, the spinal nerve roots, and the meninges. As shown in this anatomical preparation, two spinal roots emerge from each side of the spinal cord, a ventral, a smaller motor root, and a dorsal, thicker sensory root. As demonstrated by Habler, all motor fibers travel through the ventral root, although this root may also contain a small percentage of sensory fibers with aberrant trajectories. The course of the spinal roots becomes progressively more vertical as they progress to the lumbosacral segments, where they form the cauda equina. As Streeter suggested at the half of the last century, the formation of the cauda equina should be explained by the fast growth of the spine in relation to the growth of the spinal cord. The attachment of the spinal roots to the intervertebral foramina will then determine their progressive elongation and vertical disposition. With current MRI techniques on T2 sequences, it is possible to distinguish the smaller motor roots from the thicker sensory roots. The roots of the cauda equina occupy the most dorsal regions of the dural sac. This position, however, is not fixed and depends on the patient position. For example, in lateral decuvit, the roots move laterally, as well as on the degree of leg flexion, which causes an anterior displacement of the roots. This is the normal view of the cauda equina filling the dorsal dural sac due to the supine position of the patient during scanning. For a better visualization, we can remove the vertebral bodies, making it easy to distinguish between motor and the sensory roots. We are interested in the analysis of the spatial disposition of the roots to determine their topographic organization. To achieve this, we have reconstructed the trajectory of the sensory roots, which tend to occupy the most peripheral regions of the dural sac, and also the motor roots that in general have a more central position. The dorsal view of the cauda equina shows that its nerve roots have a more compact arrangement at L2, L3 levels than L4, L5 interspace. And the motor roots in red tend to be more exposed to injury in the midline. Regarding the meninges, there are three membranes that envelope the spinal cord as concentric sheets, called the pia mater, the innermost, the dura mater, the outermost, and the arachnoid membrane in between. We will briefly describe only the dura mater, which is directly visible with MRI techniques. As we can see in this dissection of a newborn spine, the dural sac emits lateral extensions or dural sleeves. These sleeves surround the spinal roots at their exit through the intervertebral foramina. In this sagittal section from an adult spine that crosses through the intervertebral foramina, the arrangement of the dural sleeves are also visible, containing the anterior motor root and the posterior sensory root, surrounded by a venous plexus. This plexus allows the communication between the internal and the external vertebral plexuses. In turn, the internal plexus, which drains venous blood from the vertebral canal and fills the epidural space, is organized in a large anterior vertebral plexus, extensively connected in the lateral part with a more discrete posterior venous plexus that usually spares the midline. The arterial supply of the spinal cord depends on small segmental radiculomedullary arteries. They enter the intervertebral foramen and are divided into ventral and dorsal root branches. These branches contribute to the formation of the anterior and the posterior pyrate posterior spinal arteries, respectively. On T1 weighted images, the dural sac appears as a dark structure extending from the foramen magnum to the second sacral vertebra. Its wall is thicker on the posterior surface as compared with the thinner anterior surface. By moving the section plane laterally, the intervertebral foramen is rigid, which contains the dorsal root ganglion and the venous plexus described previously. In the axial plane, it's possible to see how the dural slits emerge on both sides of the dural sac, as we can see here at this point, occupying the lateral recess before leaving the intervertebral foramen. These relationships becomes more evident through the three-dimensional reconstruction of the dural surface that also shows the thickening corresponding to the dorsal root ganglion. After exiting the intervertebral foramen, each spinal nerve divides into a ventral and a dorsal ramus. This last innervates the zygapophysis and other posterior structures. The dural sac is densely innervated by sensory and autonomic fibers, forming a plexus on its anterior surface. This anterior dural plexus receives contributions from the meningeal branch of the sinovertebral nerve, the nerve plexus from the posterior longitudinal ligament, and fibers from the perivascular plexus of the radicular arteries. This kind of three-dimensional models has been used by our group to design a system for intrathecal and epidural drug delivery simulation. The system should display the posterior vertebral arc and the different ligaments described previously. In the early days of neuromodulation, most clinicians recommend a classic medial approach to the spine. The needles perforates, at this point, the skin, the cellular subcutaneous tissue, and the supraspinous, interspinous, the flavum ligaments to finally reach the posterior epidural fat pad and eventually the dural sac. Currently, a technique that involves using a paramedian approach is preferred. In a first step, the vertebral pedicle is identified on an anteroposterior projection, for example, the pedicle of L5. Then the skin is marked at the inferior aspect of this pedicle at about 1 to 2 centimeters from the midline. And finally, the needle is entered with an acute angle of 30 to 45 degrees to reach the interlaminar space 1.5 above the select entry point, in this case between L3 and L4. I'd like to conclude this session by thanking all persons who have helped me in the preparation of this presentation, and especially Dr. Reina from Monte Principe University Hospital, Professor De Andrés from Valencia University General Hospital, Dr. Puigdevol, Dr. Yusuf from my university, and techniques like Olga Fuentes and Professor Carrera and Colano from the University of Girona and our university. And thank you very much for your attention. I hope to see you soon.